Hello, and thank you for tuning in to this important conversation. My name is Dr. Joanna Cohen, and I am Director of the Institute for Global Tobacco Control at the Johns Hopkins Bloomberg School of Public Health. Sunday, May 31st is World No Tobacco Day. We have shared information throughout May focusing on the 2020 World No Tobacco Day theme, exposing the tactics that the tobacco industry uses to prey on young people. We close out our World No Tobacco Day activities with a discussion on COVID-19 and tobacco control with Dr. Enid Neptune, Associate Professor of Medicine at the Johns Hopkins University School of Medicine. Dr. Neptune is a pulmonary and critical care specialist. So thank you very much for joining me today.
Oh, well, thank you for inviting me.
As more information becomes available, do we have an idea of what role tobacco use plays in susceptibility to the coronavirus?
I would say yes and no. And I'm not being intentionally oblique. The challenge is how would we determine if tobacco has a role in susceptibility? The ideal scenario would be that we have two effectively matched groups of smokers and non-smokers that were both exposed to the same dose of virus, and we were able to monitor them over time to see if they established infection. Another reasonable approach would be to employ broad-scale surveillance of an at-risk population and determine whether there's an increased prevalence of smokers among those who develop infection or who are positive. The studies that we are currently seeing published are much more muddled. The typical approach in these studies is that we compare the proportion of smokers among hospitalized COVID-19 patients with the proportion of smokers in the general population. And if we use a preponderance of evidence standard in those types of studies, I would say that the data is mixed, and not just in one country. It's actually mixed in China, it's mixed in Europe, and it's also mixed, yes, in the United States. And so there are many challenges to these types of studies. One is the issue of classification. Do we group former smokers with active smokers, or do we group them with non-smokers? And the other confounder is the overall clinical climate in which this information is being obtained. We assume that the ascertainment of tobacco use is not a high priority when you're dealing with a pandemic. And so we may very well not have the most accurate, the most complete data sets in many of these situations. But I think we're left with meta-analyses and case series that will help us to understand whether this is a true and an important risk factor. And we'll probably see a wave of new studies that will be educated by the flaws and the omissions of the earlier studies, and thus will give us a great deal more reliable information about this association. But one thing I think we should think about is what can we predict from just a purely pathophysiologic perspective? I mean, we know that the upper airway is the portal of entry, and that is how most people become infected. The droplets land on the mucosal membranes in our mouths, in our nose. And we generally believe that injured or inflamed tissue in the upper airway create a hospitable environment for all types of pathogens, bacteria, viruses, fungi. And so because we know that long-term smokers have inflamed mucous membranes in their upper airway as well as in their lower airway, in their lungs proper, it's a reasonable prediction that smokers, especially active smokers, would be at much higher risk of becoming infected with the COVID virus, which is SARS-CoV-2. But there's some other theories that we can discuss a little bit later. I want to add a little bit of kind of wonky data to this. We've had some broad surveys of all of the cells lining the upper and lower airways in the lungs to determine kind of which are the cells that have the highest levels of this protein that we generally believe is the COVID virus receptor. And it turns out that the lung cells or the airway cells that have the highest levels of expression are actually those in the nose. So that makes sense because that's what we would consider a portal of entry. But another bit of wonky data is that when people have done surveys of the levels of expression in smokers or in animal models of smokers, we find that there's an increase in the levels of these receptors. And what this suggests is that maybe smoking status will increase the ability of the virus to interact with the cells and possibly gain cell entry. And so hopefully we're going to get much more data about this potential mechanism as more and more people do studies and more of these studies are published in peer-reviewed journals.
Well, thanks so much. That's really helpful, and I appreciate you discussing the nuances of the science. You know, everyone wants to get information quickly and out there so we can learn from it, but it does take time to do rigorous studies and to get to the right answer, and it takes multiple studies. So thank you for explaining that to us. Can you tell us, Dr. Neptune, what we know at the current time about the role tobacco use plays in COVID-19 disease severity and death?
That's an excellent question. And actually, we have much more informative data on that issue. Like I did before, I think it's always helpful to present kind of the ideal scenario or how we would like for these studies to be conducted. And then I will tell you how these studies are generally being conducted in the real world. What we would ideally like is to have smokers and non-smokers who have active COVID infections who encounter the medical system at exactly the same point in the evolution of their illness. Now, since this time zero, that means the time when you're first infected, has been difficult to establish in most people. Convenient parameters are typically the days of fever or the day at which your oxygen level starts to drop. Now, those are flawed parameters, but they're reasonable to use kind of in this type of clinical climate. But most of the studies are published use a different strategy. What they do is that they focus on the percentage of smokers among hospitalized COVID patients that require ICU care, mechanical ventilation, or who ultimately die versus those who are hospitalized and do not develop those severe and concerning outcomes. But using that investigative structure, albeit flawed, the preponderance of data does suggest that those who are smokers have a greater severity of illness and therefore have the most feared outcomes being ICU care, mechanical ventilation, and death. Now, one confounding factor to those studies is whether the smokers have underlying lung disease or an underlying comorbidity, such as COPD, emphysema, or even scarring of the lungs. That studies looking at these predisposing lung conditions in hospitalized patients persuasively show that those patients have worse outcomes. And that makes sense because one can easily imagine that any disorder that would compromise what we call your respiratory reserve, and that means your ability to tolerate any kind of respiratory insult, that those diseases would lead to worse outcomes when you have a second hit. I mean, that's akin to being a football player or being a boxer that has a lot of protective gear on and having to sustain some type of a body blow, that you would very much develop more pain and obviously more injury if you did not have those types of protective gear on. And it's the same with the lungs. So what we're seeing with COVID is not surprising and is basically what we see with other respiratory viruses. But I want to throw in a complicating curveball with respect to the question of whether smoking worsens these clinical outcomes. I brought up this issue of the receptor, and I know that sounds wonky, and I know a lot of people don't want to think about these proteins or these receptors, But it's important because that adds to the whole complexity of this pandemic. This receptor, kind of in normal circumstances, outside of the COVID epidemic, is protective. And that means if you get a regular cold or you get a regular flu, you would want to have higher levels of that receptor in your lungs because it actually reduces inflammation and promotes repair of your lungs. And so you can imagine kind of this constellation with COVID, where you have a virus that uses your protective receptor in order to gain entry to the lungs. And secondarily, and this is what's really interesting about this virus, reduces the levels of this receptor so that the protective functions that you would need in order to ultimately recover from the virus are compromised. And so that is why we consider COVID virus as an incredibly skillful pathogen.
Yeah, unfortunately for us.
Unfortunately for us.
Thank you for explaining that. So, you know, Dr. Neptune, there's a lot of interest everywhere about vaping. Would you expect the effects of vaping regarding the coronavirus to be similar to the effects that we might be seeing or that might occur with smoking? And you did explain that we're still trying to get stronger science, but I guess from more of a pathological, physiological perspective, do you think the effects might be similar or different in particular ways?
That's actually a really good question. And I think to some extent, yes. And that's because over the last 4 or 5 years, and you know this data very well, that there have been kind of an emergence of information about the lung consequences of vaping. And what we know is that chronic vaping does lead to low levels of inflammation and injury in the airways and in the lungs. And although not identical, there are meaningful similarities in the types of inflammation that we see in the lungs of smokers and what we see in the lungs of people who chronically vape. We also know that there has been this recent epidemic of the vaping-associated lung injury that occurred in both acute as well as chronic settings. And those two kind of findings in reality kind of make us highly suspicious that persons who vape may have kind of an increased susceptibility and may also have an increased severity of illness in the setting of active infection. It's very interesting because one of the potential explanations for the increased proportion of young people with COVID who are hospitalized in the United States compared to the data that came out of China and Wuhan is potentially, and we haven't validated this, but one of the things that we were strongly considering is maybe that reflected the increased proportion of young adults and teenagers who vape in this country compared to other countries. And that's obviously going to have to be tested with much more complete kind of data sets of the young versus old populations in this country. And there's also been the other kind of interest in whether there were cases, especially in late December and early January, among young people that may have been hospitalized for acute respiratory illnesses that were misclassified as vaping-associated lung injury, but may in fact have been bona fide COVID infections. So this whole issue of vaping in the United States kind of creates other levels of concern in terms of our young population of people who are kind of surprisingly much more sick than one would expect given the early data from China.
Yeah, so it does take time to do good science, and there are interesting pieces and threads of data that just need further explanation and study. And so hopefully we can get those better data as things calm down, as you said, like in current critical climate, it's really hard to collect really good data. There's a hypothesis circulating right now that nicotine might actually protect people against coronavirus infection. So as a pulmonary specialist, what are your thoughts about this hypothesis?
I think that this idea is highly problematic on several levels. I typically view what I call the nicotine good arguments as a reflection of how many logistical contortions one has to perform to reach that conclusion. And I also, and this is from a purely kind of practical perspective, like to determine whether the argument ends with the support of e-cigarette use. And that would indicate that there might be another kind of motivation behind the data. But taking this from kind of a totally objective perspective, we know that smoking and nicotine can have both protective as well as harmful effects in the lungs when you look at studies that have been done in animal models as well as in cell models. It has both pro-inflammatory and anti-inflammatory effects. It has both pro-repair and anti-repair effects in the lungs and the tissue. So one can argue kind of whether nicotine has a positive effect, or one can argue whether nicotine has a negative effect in a fairly compelling fashion. And so what we have to wait for are really, really compelling studies in which we use cells and we use animal models and we expose them to nicotine plus minus the virus and see whether nicotine is in fact protective. And before we have those studies, I think we have to have kind of a very kind of cautious posture about this issue. But I also want to mention that this idea is very risky from a public health standpoint, given the pandemic and the argument that nicotine has some salutary effects, because the kind of encouragement of populations to use tobacco products, given what we know about the harm, is problematic. And I think we should be very, very cautious in advancing that notion without much more persuasive data.
Thank you for that. So I'd like to finish up our discussion with a question about smoking cessation. Could the shelter-in-place orders that we're all under now provide a useful setting for quit attempts? And a second part of this question, would the symptoms of reduced taste and or smell make smoking cessation more or less tolerable for smokers?
Oh, I love this question, because I think one of the concerns that many of us who work with tobacco cessation and tobacco control have had with this epidemic is that, you know, how is that affecting that population, the very vulnerable population of active smokers who are interested in quitting? I agree with you. I would imagine that a home environment, assuming that one's cohabitants are non-smokers, would be a very helpful setting for a quit attempt. And the exaggerated concern that many people have about the health of their family members, their spouses, when they're kind of in lockdown or in these socially isolated situations, would also make kind of the uptake of tobacco product use much less appealing. And I also am intrigued by the idea that these kind of symptoms of reduced kind of smell and reduced taste and how that would affect kind of one's interest in smoking. And I think because you know that the triggers for smoking are often based on those types of senses, the taste, the smell, and also that the satisfaction that many people get with smoking are also kind of based on those senses. So it makes sense that it might be somewhat easier to pursue a quit attempt in kind of social isolation, or when you're kind of in your home with other people who are not smoking. And the last point about the quit attempt, I think we should recognize, and it's something that many of us kind of talk about, but has not really become kind of ingrained in the larger population. And that is that any hospitalization for more than 1, 2, 3 days represents a quit attempt in an active smoker, because persons aren't allowed to smoke when they're hospitalized. And because of the complexity of most of the patients who are hospitalized with COVID, any smoker that is hospitalized is effectively engaging in a quit attempt. And we're talking about hospitalizations that can run from 7, 14, 21 days or even longer. And so one really interesting question is, what happens when these patients are discharged? What is the survivor experience with respect to smoking? Is there a lower likelihood of resuming smoking, or is there a higher likelihood? And the higher likelihood possibility, I think, is something we have to take seriously because of the I would say almost inchoate stress and anxiety that surrounds this pandemic. We all know that people smoke or engage in kind of adverse behaviors, unfortunate behaviors, when they're in very, very stressful situations. And so one of the concerns that we all should have is whether persons who are smokers need more support and more engagement and more creative options in terms of smoking cessation or maintaining smoking cessation during this pandemic. And I was really encouraged, Joanna, when the New York Times a few weeks ago, and I'm sure you saw this, had an article that specifically addressed kind of the availability of services for people who are trying to quit smoking during the pandemic. And I think all of us on a local level should encourage the greater visibility of those options, because I think they will be highly needed. And from a research perspective, as someone who's following these patients and is engaged in kind of structures to kind of look at these patients post-discharge, one of the questions that we want to pursue is how they're continuing with their smoking cessation efforts, whether they're more interested, and what we can do to support them.
Well, thank you for highlighting the importance of smoking cessation and supporting smokers in their quit attempts. Behavior change is difficult for everyone, and this is, when you add in addiction, it's even harder. But people do it, and they need support, and it's up to us to support them. There are 1-800-QUIT lines. There are physicians and nurses and pharmacists who can help support quit attempts, and there are approved smoking cessation medications that can assist as well. So thank you so much for the research that you're doing, and for the clinical work that you're doing, and I really appreciate you taking the time during this very busy time to talk with us and provide a real expert perspective on COVID-19 and tobacco use. Thank you so much, Dr. Neptune.
You're very welcome.